Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Welcome back to the podcast. On today's episode, we have Dr. Arielle Rubin. She's a child psychiatrist who's also active in the autism education and advocacy through community lectures. Her blog, ariellerubinmd.com, and her Instagram, @Arielle Rubin. So she holds a faculty position as assistant clinical professor in the Division of Psychiatry and Child Health at the University of Arizona College of Medicine, Phoenix, which is where she did her child psych fellowship. So Dr. Rubin, thank you so much for being on the podcast.
Thank you for having me.
So we're going to be talking about autism and autism spectrum disorders today. So can you tell the audience why I asked you to focus, of all the child psychiatrists out there, why I asked you to focus on that particular topic?
Yeah, absolutely. So I think you were able to see through some of the media I put out there, some of the information that I've been talking about in my lectures. While I am a board certified child, adolescent, and adult psychiatrist, really my focus and my niche within the psychiatry space is autism, mental health, and co-occurring conditions. And while all psychiatrists and all child psychiatrists do get some training in autism and managing co-occurring conditions, it's really a subspecialty of managing autism-related co-occurring conditions. And so there are a few of us here in the Valley, but it's not common among all child psychiatrists and especially among all adult psychiatrists to have this extra level of expertise. And so that's been what I've been focusing my career on really after graduating fellowship. And so I'm glad that came through in the information that I've been presenting online spaces, that you were able to see that. We were able to connect over the shared interests.
And so what I want to talk about today is what you would like every physician out there to know about autism spectrum disorder, because we encounter it. Like, I'm an otolaryngologist. I see kids, I see adults. Some of them have it. And when I'm talking to parents about ear tubes in their kid with this additional issue, what is it that I should know? And so what is it that you wish all physicians knew? And so what I want to start with is just, how is autism currently defined? Let's agree on a definition here.
So great question. So I actually like new vocabulary that's described autism as a neurotype. And that's some of the new, more neurodiversity affirming language that we're using. So in the medical space, we do consider it a neurodevelopmental disorder in the sense that it diverges in many ways: social development, emotional development, oftentimes motor skills, from what we would expect for typical childhood development. And in that case, it is a neurodevelopmental disorder. We're also considering now that it's so inherently tied with someone's personality. And so this term neurotype has come out, and I found that's oftentimes very well received by patients and different neurowiring, and we all have different brain types, and that's okay, and that can be a good thing. But in terms of clinical criteria, when I'm actually making a diagnosis and seeing a patient in my office, I'm looking for three main diagnostic categories. And I think that's important to know because there is no test by itself, no psychological test that will 100% definitively say a person does or does not have autism. Even the gold standard tests that we use all have to be interpreted with clinical opinion. Patients come to us hoping that it would be that way, but it's often more complicated. So we look for the domains of restricted or repetitive interests. This can also be in ways that we see sometimes some difficulties with flexible thinking, or what might come off to others as rigid, but that's a criteria: repetitive, rigid thinking, difficulties with transitions. And then you have another domain, which is social impairments. And I think this is really important because it's not always that patients don't want to be social. That can be misnomer, so to speak, but some kind of social deficit or social mismatch, especially compared to that person's development. And then the last domain that we're looking at is sensory issues. So that can be hyperreactive to certain sensory stimuli, or also hyporeactive, or also a mix. So really, in my mind, when I'm meeting someone as a psychiatrist, as a physician, I'm looking at those three different symptom domains of the sensory issues, the social piece, and some difficulties with either repetitive or rigid thinking. And as you can imagine, each of those buckets can have varying symptom presentations. But once I keep those in mind, it can help me tease out my questions further and have enough symptoms in each of those buckets that I can say, yeah, this matches an autism spectrum picture.
That's interesting because it seems to share a bit with ADHD, right? That hyperfocus that they get, it's like that repetitive nature. It seems to be similar to the hyperfocus. They can have challenges with transitions. So there seems to be a significant overlap between those two.
There's a lot of diagnostic overlap, which is why for actually a period in the DSM, if you were diagnosed with one, you could not be diagnosed with the other. So if you were diagnosed with ADHD, you couldn't be diagnosed with autism, and vice versa, actually until 2013, because sometimes they seem so similar. So we thought one had to be explained by the other. But now we actually know that you can have both, and that the hyper-focus flavor that you see in ADHD might be different than what in autism. And so when you really get to know it well, you can start to tease out what some of those symptom domains look like, even though they can look very similar or sometimes parallel each other.
It's interesting that you use the word flavor, because a term that I've heard thrown about recently has been neurospicy, right? You've got someone who may have some of the characteristics of ADHD or may have some of the characteristics of autism spectrum disorder, maybe both of them. And so they refer to themselves as being neurospicy, to the point where like it's even a little bit of trendy to say that you're not neurotypical, right? So as someone who treats these patients, what are your thoughts on that? Because it seems like it would be nice in one degree because then people are more accepting, but also it might even trivialize some people's experiences.
Yeah. No, it's a great question, because I've actually had patients with both. I've had patients that really find the term offensive and find that it trivializes what they have going on. Oh, this is a casual TikTok thing, and I feel like I actually have a real disability here. And then I have other patients that feel such empowerment from it. And yes, this is me celebrating who I am. And it's not a disorder or disability. There's nothing wrong with me. I just have a different way of thinking, and that's okay. So I've learned to be flexible with it. I'm very clear in my notes, and when I'm talking to patients, that however you choose to define yourself that makes sense to you, I support that. In my clinical documentation, for many reasons, I have to speak more, medical jargon, and that's important for me to understand what's going on and also communicate with other doctors. And I found that giving patients that choice of taking ownership of the language, similar, you could say a couple years back, the debate used to be, do you say that you're autistic or that you have autism? And even within that space, there are differing opinions. So I've come to see the neurospicy thing as a similar way. And you see me use flavor because I tend to use what seems to resonate with patients is talking about it in that way, of different spicy flavor. They're like, okay, that's not so stigmatizing. I can roll with that. But I have some that like to be more professional or clinical and stay in those terms, or focus on impairments, and that resonates more. So then I will switch my language that way. But most of the time, this neurospicy, neurodivergent in a positive way is taking off, and anything that can help these patients with self-esteem, because that's a common issue, I will roll with it and be flexible.
And a diverse society, a society that is neurodiverse, is going to be more healthy than a society that is neurohomogenous. And so people that bring these other strengths and weaknesses, right? Diversity is going to strengthen the society.
I try to focus on that a lot with my patients, especially because they're often coming to see me for their impairments, right? Or what's not going well. So I try to focus on the positives and the neurodiversity and that human fabric that you talk about. Hey, we do need you, and you do have gifts, and they didn't come for free to help you with some of the struggles. There's a reason that autism is still part of the human fabric.
One of the things I like to talk about on the show is misinformation. There's so much misinformation and disinformation out there. And I would imagine there's just a ton of it on autism. And by the way, should we be referring to it as autism or autism spectrum disorder for the rest of the episode?
Autism spectrum disorder is a clinical term we use in psychiatry. There is some debate among autistic people having different feelings about calling it a disorder, and some feel that's very fair because they feel impaired and disabled by it. Others don't like that. So I usually say autism spectrum and drop the disorder piece because I find that's a little less controversial. But most patients that I see are flexible. But I usually say autism or autism spectrum most of the time.
Autism. Okay. For brevity's sake, we'll say autism. So is there any misinformation about either autism itself or the treatment thereof that you would like to dispel among the physician community?
Oh, there is so much. So it's hard to know where to begin. I think the most common one that physicians are pretty well aware of and in agreement is that vaccines don't cause autism, but that's something we still have to counsel patients about. So that one comes up a lot, but we're pretty familiar with it. But newer ones that I've seen popping up from parents asking, did screen time cause this? That's a common one that's being circulated out there and causing their child's neurodevelopmental condition. So I always say no to that. Where I do see misconception among physicians themselves sometimes is assuming that autistic patients, and particularly autistic patients that are non-speaking, also have co-occurring intellectual disability. And so I think we have to be careful to not assume that because we can't get verbal communication, that doesn't mean that they're not understanding what we're saying and at an equal or high intelligence level. I've seen those mismatches sometimes in the room. The other thing that I've noticed patients come to me asking about and sometimes get referrals for alternative treatments for managing co-occurring autism issues. So there are a lot of wellness clinics that pop up offering hyperbaric oxygen treatments, detox from heavy metals, those kind of things. And those are things parents have genuine questions about, and we have to counsel them. That kind of like the vaccine thing, those are really not evidence-based, and like any intervention can have side effects and harm. And so sometimes it's just reassuring parents knowing there is no magic thing we are not working towards a cure, and having physicians from different specialties kind of counsel that this is the way your child is. And I think is a big one.
They hear it from multiple places, right? I remember I had a patient who got vaccinated. He heard it from me and he wasn't going to get back. This was back in COVID, right? The height of COVID, he wasn't getting vaccinated. And then he heard it from his primary care physician, and he heard it from his orthopedic surgeon, and he heard it from someone else. And everyone said the same thing. So he was like, listen, if everyone's told, all right, fine. You've convinced me. I've heard it from
if
enough
we're all
experts out
consistent
there.
on the same page. Absolutely.
Yeah. So it's great.
The other one that I see sometimes, which goes with the sensory piece, is there's a myth that autistic patients don't feel or perceive pain. And so this can happen a lot of the times in ERs, for example, with fractures or different conditions, or it can't be that severe because they're not showing that much pain. Or even some patients that are able to speak and you ask them to rate their pain, you might get a lower number. And so what I say with that is the expression of pain perception might be different because of that sensory responsiveness. But oftentimes after the fact, they'll be able to say that was extremely painful, or I wasn't able to say it in the moment, or I wasn't able to show it. And so I think we want to be extra cautious about making assumptions based on what we would normally assume pain would look like in a subjective exam. I've had patients that have walked around for months with fractures in their foot or a broken collarbone. Nobody knew because it didn't look like they were in pain. So they didn't get imaging or follow it up further. So being really careful with that pain piece and treating the pain like you would treat another patient that would have whatever medical issue you think is going on, what would be appropriate pain management or workup for that. That would be another thing to consider in being thorough, because a lot of these patients can't give you the detailed history sometimes that you'd like or in the way that you like it. Being extra thorough and extra cautious and really trying to take a step back and not make assumptions can be helpful. I could keep going on with the misinformation, but those are some top of mind ones that I have.
And actually, you mentioned the wellness influencers out there. We're going to be doing an episode in a couple of weeks with Dr. Jonathan Stia, who is a psychologist. And we're going to be talking all about the confluence of the anti-psychiatry movement and the wellness
that'll
movement.
be good.
So,
That'll be good.
So we're going to be a whole episode, and he's written a whole book about that. But I love what you said about the pain piece, about how we shouldn't be. And so that's something for all of us to keep in mind when we're seeing someone with autism that they might not express. Because often when I'm doing a procedure, I've got like the corner of my eye looking at their facial expressions to see if it's making them uncomfortable or not. And so now I know I can't rely on that with those particular patients. And so there needs to be maybe constant feedback, asking them questions, or just having to make assumptions of this might be uncomfortable and I might not be hearing it from them.
Yes, absolutely.
It's great advice. So let's say we're an adult practitioner. We see adults, we notice the patient comes in with traits that would be consistent with autism, right? But they live independently. They might be unaware that they even have some similar traits to someone with autism. Maybe they have the diagnosis, maybe not. But what are some other things that you want us to consider about that patient? The pain piece we just discussed. Anything else for our adult patients who are able to live independently that we need to keep in mind?
Yeah, so I think there's a lot of things we can do that whatever specialty we're in, if we notice that there may be an autism spectrum component going on, is how can we make that patient most comfortable in whatever reason we're there to serve them? So still focusing on the chief complaint that they came to see you in, whatever your specialty is, but being sensitive to autism-related needs. And I think one of the things that comes up the most in clinical practice is the sensory needs and even autistic adults. So offices, for example, that have very bright lights, sometimes with a patient, I have an adult coming in, I might turn the lights down a little bit just so they're not so intense, or ask them, hey, is the lighting okay? How is my volume? I'm speaking too loud. Would you like me to tone my voice down? Because sometimes they can think that you're yelling because of that sensory perception, but you're not, but it just is perceived higher. And they may not tell you, but there may just be more anxiety in the room. So if you're noticing tensing, hey, are you hearing me okay? Or I can tone it down and whatever makes you more comfortable. Just opening that up, that I'm here to be flexible in my style. Another thing I would say, and this is not a blanket rule, but a lot of autistic patients are uncomfortable with eye contact. A lot of adults can do it. And they can mask and force themselves to make eye contact because they know socially that's conventional and that's usually how you show interest. But it can be really uncomfortable. And there's different neurodevelopmental reasons we think for that. There's different parts of the brain that we think process the eye contact and can be more sensitive. Also knowing that what I try to do is not directly look at someone's eyes intensely, or have breaks and kind of sense, okay, are they looking at me? Give them breaks. But also I tell them as we're talking, and this is more in a psychiatry sense, but you could do this in other times too, is, hey, by the way, I notice if sometimes you don't want to, look directly at me, I'm still listening. It's okay. Taking that pressure off so they don't have to, what we call, quote unquote, mask of trying to appear neurotypical, look at the doctor in the eye. So if he knows I'm paying attention, and creating a little bit of that flexible space.
For most of us, what we can do is we can just go back to typing on our computer. Because if we're looking at our computer, then we're taking the pressure off of them to make eye contact. And that's where we want our faces. And
And I think the big one too is I tell them that they don't have to make it with me. But I try to also find, if you have a patient that you think is on the spectrum, finding alternative ways to connect can be great. So social chit chat sometimes works for some, but others, if you happen to know that your patient is interested in any areas, whether it's what their career is or something that's a hobby, finding special interests to talk about, knowing a little bit about your patient can really open them up. Whereas otherwise there can be a lot of anxiety in those doctor's visits and not really sure what to talk about or keep the conversation going. So I try to keep those low pressure encounters, find something they're interested in, and keep things not dragging on in the conversation of really being sensitive. What is their social battery? And I'm not pushing anything. The other thing, like you mentioned in the beginning of the podcast, is there's a very high co-occurring rate with ADHD. And so processing time can be affected. So repeating instructions and being very clear and concrete with what you would like the person to do is very helpful. I find writing down instructions and giving them after the visit and a good discharge summary, because these are patients that if it's written for them, they will do it to a T a lot of the time because it's very detail oriented in that sense. But processing, a lot of times there's anxiety in the visits, which we know can happen to a lot of patients. Being extra clear that I'm saying it in short pieces that they can digest, make sure they're processing with me, and then giving something for them after the visit as well that has clear instructions. That's going to help a lot because a lot of times there's missed pieces in the room. But again, because of that social anxiety, they don't want to say anything that the parts are missed. And so, yeah, I got it. But to be extra sure, that's one thing I would recommend is having clear, short instructions, but giving them something after that they can take with them to review to make sure everything's clear.
Amazing. And if that's part of your routine, then fantastic. It really ideally should be part of our routines anyway for every patient.
Yeah.
I would argue for any patient that identifies as male, you should probably have very clearly written instructions for them, because for all my male patients out there, they tend to minimize their symptoms and then forget everything the doctor told them. They'll go, someone will ask them, oh, what'd the doctor say? Like, oh, they said it was fine. Actually, that's not what I said at all. More important for patients with autism, but really everybody, I think that specific piece about the instructions should be, we should try our best to make it part of it. Am I saying that I do that every time? No. Should I be striving to? Yes. So what about some of the challenges that our pediatric patients might face? Something that we want to keep in mind for the parents of kids with autism when we're treating them. If, for instance, I have a kid that I'm going to be taking out their tonsils and their adenoids and putting in ear tubes, right? How should I interface with the family differently than for a neurotypical child?
I think it's great also that you're thinking about it. And I think even the fact that you think about it and keep that in mind, you're already going to deliver better care because you're aware. And one of the things to be aware of, seeing these autistic patients and their families, I often come at it from a trauma-informed perspective that usually these kids have been through some type of, if not medical trauma, of being invalidated at doctor's appointments and having traumatic experiences. I actually see that not infrequently. These are kids that have been bullied. These are people that have been turned away for therapies that they need, families that have been judged because of their kids' behaviors. Why can't you control your kid? So they come in on like high alert and like a hyper vigilance a lot of the times.
Yeah.
And so knowing that, almost like you would approach a patient with trauma, of like, all right, take a step back and really just make them comfortable and realize how much it took for them to get here, and sometimes even get out of the house and get in the car, can help ease things that it's different. And sometimes we have to slow things down just from that reason. Again, from a sensory perspective, but also an anxiety perspective, a lot of these kids come in and they're very nervous and they're in a different environment. They transition to somewhere new. And then the doctor comes in and might want to do a procedure or touch them or do something. And that can be very scary. So if you don't know what to do, sometimes I think it can be great to involve the parent and say, hey, what have you noticed works for him when he's, nervous? Do you want to maybe touch him first? Or maybe you touch his belly and then the doctor touches his belly or something. We're bringing in a safe person and walking that person through the exam more. I've had sometimes pediatricians where they'll let the kid come in early before the appointment and just walk around to get familiar with the scene, feel the blood pressure cuff, or if they're getting an EEG from neurology, putting that on or seeing what it looks like, playing with at home. So any kind of warm up things you can do can be very helpful. And also announcing anything you're going to do. Okay, I'm going to palpate your thyroid now, or touch your belly, or we're going to look in your ears. It looks like this. And sometimes the kids like to look at the probe and what's it going to be. I've had some autistic patients that like to, just to feel control, hold the hand of the doctor. If they're putting an otoscope in, like they want to hold it and just control the rate that it's going in. So again, being flexible with your physical exam skills and accommodating to the kid, and also bringing the parent involved and being comfortable with that flexibility can relax them a lot. And the other thing I would say is, if you notice if a kid is, whether it's in your office or let's say surgery, and you're seeing extreme behavioral issues, like the kid is having a meltdown, they're not able to come out from the waiting room, and that, taking just a moment to say to parents, I realize this is really hard, and I realize he's having a hard time. How are you guys doing with it? And then a lot of times they could say, I'm exhausted, we don't know what to do. And then having at least a couple of referrals in your area, whether it's for a psychiatrist, a therapist, a developmental pediatrician, just somebody say, hey, here's a next step of somebody good that I know to call. And just being that bridge of recognizing, hey, I know it's not what you're here for to see me, but I see it, that there's this other thing going on. I empathize with it, and here's something to get you to the next step. Again, that can also decrease the parent's anxiety of, okay, he's not, judging me. He sees it and sees it as some, medical or psychiatric thing that could get help. I find that they respond, they're like, oh yeah, I've had patients referred to me by orthopedists, ENTs, surgeons of, hey, we noticed something, or hey, we were trying to do a colonoscopy and it really didn't go well. And then we found out about all these other issues. Can you send them to me? So having a couple of colleagues and being quick to empathically offer those referrals, that's something that could really help parents and families in the pediatric and in the adult space.
Great ideas. So you mentioned colleagues. So let's talk a little about that too. So we might have colleagues who we notice. They might carry the diagnosis. Maybe they just have some traits. Might be a colleague, might be a trainee. So what recommendations would you have about how to best interact with those colleagues? And by the way, a lot of your advice that you're giving so far really works for everybody, right? Like neurotypical people, like just a kid with anxiety, like all those tips and tricks that you used are things that are going to work really well. And they might take a little more time, but oh my goodness, are they going to save you time also? Because you're going to avoid that kid and meltdown. You're going to avoid them screaming and yelling, or at least some of the time it's going to do. So the little bit of investment is definitely going to pay off. So a lot of the advice really applies to everybody and how to treat them, right? In a trauma-informed way, in a, I don't know if there's a term, anxiety-informed way. So I'm looking for similar advice now for either colleagues or trainees that might have this same issue.
Yeah, absolutely. And my advice from the trainee for the colleague perspective is a little bit different. So I'll start with the trainee piece. So I think that's a really unique perspective, because when you're attending, let's say with a trainee, there is that authority differential, you could say, but also you have a unique role there that is a teaching role and kind of shaping who that person is going to be as a physician. And so I think with that comes really unique opportunities to help out an autistic trainee in a couple ways, but also learn from them. So I think one step, if you have a trainee, whether it's a medical student, a resident, a fellow, and you think they might be on the autism spectrum, I think the first step is take a step and realize, wow, like realizing how far this person has come. Thinking of that as a disability that a lot of people face, even if it's emotional or psychiatric, that has not been an easy journey for them to get to point, let's say Z, from A to Z. They've gotten there. They finally got into medical school. They're there working with you. That is very difficult. And so realizing just, wow, this person has come really far. And then how can I take them further, knowing that they're going to need some extra support? And so I would say that this is usually a resident medical student trainee I would spend extra time with to make sure that things are going okay. Because again, they might have a difficult time telling you that it's not, in terms of that social communication piece. So really having close vigilance there. The other thing that I see, doctoring is complicated, right? So we have our diagnosis and our workup, but we also have that patient relationship and doctoring piece in the room. And a lot of times communication between autistic patients to autistic patients, or autistic to ADHD neurodiverse, goes very well. Sometimes with autistic to neurotypical, sometimes there can be like a wall of, hey, we're missing each other. Like we're not communicating well. So when you have an autistic trainee.
Well, that's interesting, actually, that you point that out. I didn't know that. So people with autism have an easier time communicating with other people with autism. Often it goes smoothly, is what you're saying, or ADHD to ADHD. They have an ability to communicate because they get each other intuitively better, whereas it doesn't always go in the other. Oh, that's really interesting.
Yeah. So when you see that mismatch, helping the autistic patient kind of in unexpected social patient situations, we all know we get into some really murky stuff sometimes with patients that are upset or they're anxious and they need to be reassured, and they need maybe more of a stronger emotional approach, or they need some of that more drawn out chit chat conversation before you can get to business. Realizing that different patients need different styles. Some styles in autistic trainee might need more help in learning. And that's okay. They can totally learn it, but it might need some more modeling. So those might be some situations where I said, hey, you know what? This one might need a little more emotional support in this way. This is what I do. Do you want to come watch me and check that out? And giving them different observation experiences for different styles that they can pick up into their repertoire for patient situations that might not be so comfortable. and also helping them navigate through situations with colleagues, because we know that being able to communicate with your colleagues is also a high physician skill and also has a social nuance to it, especially when you might disagree with a treatment plan or something like that. Different ways that you can do that. Hey, here's what I do. I'm being really explicit about what you do. The other thing I remember as a resident or a trainee is there's a lot of times the read the attending's mind kind of thing. What am I thinking? Game. That can be extra hard for an autistic trainee. So I try to give a little more context clues, lead them along the path to guess what I'm thinking by looking at my face. That can be, really hard. So some of the medical education strategies, some of the pimping that we would do can be tremendously anxiety provoking, even if they know the answer, just because there's a social performance situation. So I do try to tweak that way. And then the other thing I would say from a trainee perspective, and like I mentioned earlier, it happens in kids, but bullying is like a pervasive thing that can happen when you're different. And so I've even seen sometimes in residency, there's the odd resident out. And so also paying attention to how your other trainees are interacting with them, helping foster some of those social relationships, making sure nobody's being too, competitive, but really, hey, bringing them on and highlighting some of their strengths where it may be more obvious to them that, oh, this person seems odd or is struggling. And so the attending taking leadership of this is a valuable member of the team and look what they can do and what we can learn. That kind of sets the tone for the other residents, how to interact and communicate. The other thing I would say, again, with the social piece, I remember in medical training, a lot of the social stuff, when you're a medical student or a resident, you also try to talk to your attendings about their lives and try to make talk and communication with them, sometimes to impress them. If you're really trying, so there's so much of this that can be a social game to get honors or to get that letter of recommendation. And so an autistic patient that may not give you that same social chit-chat or that feedback, not to assume that's disinterest or a lack of engagement, and really try to look for other ways to get to know them, maybe finding some of their interests, but realizing that they might not show excelling in the same way that you might expect because so much is socially driven, or it might not give an elevator speech on the fly because that's just tremendously anxiety provoking. Can we show other ways to show knowledge and engagement, interest, and really focusing on those and realizing they're probably going to communicate with me a little differently, but that's okay. So those are some thoughts from the trainee perspective that I would say. From the attending perspective or attending to attending colleague, it's a little bit different because in that setting, we're not put into a teaching or a leadership role with them as much. So usually in those cases, I don't do as much of the leadership shaping modeling as I would do with a resident or a trainee. I really try to modulate my own approach in that sense. Say, okay, this person, they've made it this far. They're an expert in whatever field they're in. How can I best communicate with them and adjust my style so that we communicate well, knowing that it might be harder for them to adjust their style than it is for me to adjust mine. I've learned not to take direct feedback personally. That is not meant to be insulting or blunt. That's just direct feedback that this is what you should do. I'm like, those are very reasonable recommendations. Thank you so much. Realizing the person's not trying to be rude or curt in their responses has helped me a lot in my management of things. Even sometimes I'll explain to patients, I say, oh, that doctor, great, bedside manner seems just tough or dry, or I don't know. You know what? They're an expert in what they do. They're really smart. Conversationally, their style might be different, but I know they really care. If you feel like you need somebody else, that's okay. But I would really tell you, maybe talk about it with them. And I might let that colleague know, again, want some more social talking or spending a little longer in the room, or give them some pointers if I hear anything on the periphery that, again, we're having some social trouble. Because that's usually where the biggest thing happens sometimes. I've had a couple of autistic colleagues as well that are in the attending space, that sometimes more of like a colleague friend kind of perspective of, hey, this thing happened. Like, how would you deal with it? Of a tough situation with a boss or a hospital administrator or something, that with their approach be like, I know my approach would be very direct and to say what I think, but I feel like that's not going to end well because I've done that before and it doesn't work. So what would you do? And so if somebody asks me for advice, how to handle a situation or some pointers, then I'll give it. But I don't give unsolicited advice depending how close we are. But I usually wait for them to say, hey, what do you think of this? Depending how close we are.
Depending on the power dynamic, I don't know if anyone should be giving unsolicited advice to a colleague because they're a colleague, not a trainee. And so if they want advice, they'll ask for it. Don't start giving it out. That's the way to end up on the poop list.
Yeah. And on that line, if a window comes up of, hey, I've been thinking, do you notice that I have some challenges communicating with other colleagues, or have they said anything about my social approach? That might open a window. Sometimes they do say this or talking about it, but not going to somebody of, hey, have you considered that you're on the spectrum or autistic? Getting at somebody with that diagnosis, like, what does it go? But if that window is open and they're looking for some feedback, and they start that conversation, then you can always give, I noticed sometimes this, if that's who you are, it's not bad. But if you're asking, like, yeah, I've noticed. Okay.
Yeah.
But as feedback that they're asking for, and obviously not making a diagnosis here. If they really want to know, yeah, go a referral and go see a psychiatrist for that, and just being supportive, however, but also, again, with that, yeah, not offering unsolicited advice or unsolicited diagnoses.
Yeah, I'm a hand surgeon. Remember, I'm not making a diagnosis on you, but you know what? Yeah, I'm happy to give you the advice. Yeah. This has been a information-packed episode. So much great material, so much for us to think about when interacting with our patients, the families of our patients, our colleagues, our trainees. And so if people want to dive into more of your material, the website is Arielle Rubin, spelled Arielle, Rubin, Rubin, MD.com is her website, and same on Instagram. And Dr. Arielle Rubin, thank you so much for your time, your expertise, and all that you do for our patients.
Thanks for having me.
Thanks for listening. So please share it or like it or comment on a social media post or write us a 5-star review. Thank us again for listening to The Physician's Guide to Doctoring.